Welcome to Psoriasis Case Challenges for the Advanced Provider. My name is Stephanie Corder, and I'm the Director of Medical Affairs for the National Psoriasis Foundation. Our activity today is supported by independent educational grants from UCB, Lilly, and Johnson & Johnson. Our faculty, Veronica Richardson, is a dermatology certified nurse practitioner at the Perelman Center for Advanced Medicine at the University of Pennsylvania in Philadelphia, Pennsylvania. She sees general dermatology patients and has a passion for NP and PA education. Her disclosures are as follows, and all relevant financial relationships have been mitigated. This activity is accredited for both CME and NCPD credit and has been designated for 1 CME credit and 1 nursing continuing professional development credit. With that said, I would like to welcome Veronica Richardson.
Hi everyone, thanks for joining me and logging in to view some complex cases. So we're going to be discussing some really interesting cases that I've come across in practice, and I'm sure many of you have as well. And that's really one of the great things about caring for patients with psoriatic disease is that we're following them across the lifespan. So things are bound to pop up, whether it be surgeries or pregnancy or illness or cancer, right? So we have to know how to deal with some of these more complex scenarios. So we're going to go through each of these scenarios, and you'll notice that they are sometimes peppered with some literature that you might want to refer to, and I've pulled up screenshots of the different studies that you might want to take a look at to really help guide you in your practice. So let's go ahead and get started with our first case. So we have all different things. I'm going to choose our adventure for us here. And we're going to start off with the 24-year-old gentleman who comes to us for his initial visit. He was actually diagnosed with psoriasis about 2 years ago. He previously had limited disease that was managed with topicals, but since seeing you now, he's flaring for the past 6 months. He currently has a body surface area of 35%, and you can see just a snapshot of that of his arm here on the right. And he's really interested in starting biologic therapy, and based on his disease severity alone, you think that's probably a good idea as well. When you take a detailed history, it reveals, though, that he's never received his measles, mumps, or rubella vaccination in childhood. So how do you proceed? So do you go ahead and start the biologic and have the patient get the MMR vaccination as soon as possible? Or do you hold on starting a biologic therapy until the MMR vaccine is completed? So let's do a quick little primer and just a refresher here. What are live vaccines versus non-live vaccines? So here's a list here of our most common non-live vaccines that we come across that we often have our patients getting. And these do not require any sort of biologic or systemic agent interruption. I was presenting one time and somebody asked about meningococcal. Meningococcal is not a live vaccine, so that's absolutely safe to get. And there are more strains of the meningococcal vaccination that we're seeing, or vaccinations that cover various strains. So that is a non-live vaccine and is absolutely safe to give for patients who are receiving biologics. Now, live vaccines are in red here, and I really want to bring your attention to these. So one of note, the intranasal influenza vaccination, so the flu mist, that's a live vaccination and should be avoided. The live zoster, which was the Zostavax, that was the first shingles vaccination that had come out. It's no longer on the market. It's been replaced by the Shingrix vaccine, which is a recombinant herpes zoster vaccination here on the left-hand side, and that is a non-live. So our Shingrix vaccine is safe. The old Zostavax is not. Of course, measles, mumps, rubella is the one we're most common with in terms of live vaccines. If you have patients who are looking to travel overseas, they may require a yellow fever vaccine, right? So that's definitely one that we come across at all ages, but especially our younger population who are traveling abroad, backpacking across Europe and Southeast Asia. So thinking about those. And then, of course, smallpox and monkeypox are both live vaccines. So how do we handle this situation? So with non-live vaccines, as I mentioned, you can continue pretty much all of your oral and biologics that we have patients on for psoriasis. The one caveat there, the one call out that I do want to mention is that methotrexate, if you do have a patient on methotrexate, you ideally want to hold their methotrexate dose 2 to 4 weeks before giving a non-live vaccine and then resuming it 2 to 4 weeks after. And that has to do with some data that has been shown that methotrexate can impact the body's ability to create a substantial immune response to make then the vaccination effective. So that really is the only one scenario, methotrexate, when you have a patient who needs to get a non-live vaccine, you might want to consider interruption in therapy. Again, this is a case-by-case basis. So if you have a patient with extremely brittle disease, that may be something that you may not want to do because this patient can't tolerate a disruption in therapy. But I did want to call attention to that. Now, for our live vaccines, you do want to temporarily hold most of our oral systemic and biologic drugs both before and after administration. And the recommendations in general are to hold the dose for 2 to 3 half-lives before giving the vaccination, and then you can resume the medication 2 to 4 weeks after getting the vaccination. And some exceptions to call out here, acitretin, both acitretin and apremilast do not require a temporary hold. So you can proceed with live vaccination without interruption for both acitretin and apremilast. And actually for patients who are getting cyclosporine, I know we really aren't running into too many patients nowadays on cyclosporine, but do know that they can get a live vaccine while they're on the cyclosporine. There's no need to hold it prior to them getting the vaccine, but then we ask that you hold the dose of their biologic for 2 to 4 weeks. So hold that next dose for 2 to 4 weeks. For tofacitinib, you'd want to stop the tofacitinib 1 week before getting the live vaccination and then resume it 2 to 4 weeks after. And then for our rheumatology colleagues who are using abatacept, there are sub-Q and IV dosing. So if the patient's taking the sub-Q formulation, they should stop it 1 week before. The IV formulation, they should stop 4 weeks before getting live vaccination, and the next dose should be deferred 2 to 4 weeks after the administration of the live vaccine. And all of these recommendations come from the National Psoriasis Foundation. There was a Delphi consensus from the medical board of the NPF, and it's published here in the JAD in 2024, vaccination recommendations for results receiving biologics. So this is definitely a piece of literature that you would want to consult with if you're posed with a vaccination question. So our next case. As I mentioned earlier, we are seeing patients at all different milestones in their lifetime, and that does not exclude pregnancy. So we are seeing young women of childbearing potential who have chronic psoriasis and psoriatic arthritis, and we always get this question, what should I do if I become pregnant? So we have a 28-year-old woman with no comorbidities. She was initiated on guselkumab when her body surface area was about 25% 1 year ago. She's previously used topical steroids as well as a course of phototherapy around the age of 20. Her psoriasis improved by 100%. She has a BSA of 0 on the guselkumab after only 6 months. And at her follow-up, she informs you, hey, I'm pregnant with my first child. She wants to know if she should stop or continue the guselkumab. What do you do? I highlight this case because it's quite common for patients to become pregnant and not consult their dermatology provider. It's actually quite more common than you think. So it's not an unrealistic scenario for a patient to come to you and say, hey, I'm on this medication and, well, I'm pregnant. What should I do now? So what do we want to first think about? So when I'm looking at more complex clinical scenarios, you really want to think about, comorbidities. And it's really very important to think, okay, does this patient have anything else happening here that would make me feel one way or another about, starting or stopping this medication or continuing or stopping this medication? So she has no comorbidities, meaning she has no history of psoriatic arthritis, which is helpful for me to know. We know she has a history of severe disease. Her treatment history includes topicals and phototherapy. Okay, so she's not burned through a lot of biologic therapies. It's not like guselkumab was the fourth, fifth, sixth, or seventh biologic that she's been on. She's relatively treatment naive, and she's had a great response to the guselkumab. So here we are, 28-year-old woman with no comorbidities, relatively treatment naive, who is pregnant. So what do? What would you do? Think about it before I go to the next page. What might you do in this situation? Would you stop the guselkumab? Would you switch her to certolizumab? Would you start phototherapy thinking, oh, okay, she had phototherapy in the past? Or would you continue the guselkumab and just monitor her? So my answer was A, was to stop the guselkumab. And why did I choose that? And we're going to go through each of the different options so we really understand what kind of the decision making was and the thought process behind the decision made. So I chose to stop the guselkumab. Okay, we have a general lack of safety data for the IL-17 and the IL-23 agents, in part because they're relatively new compared to the TNF inhibitors. And as I mentioned earlier, she's relatively treatment naive and she doesn't have psoriatic arthritis. And if yes, of course, I want to keep her skin clear. But I know I'm not dealing with a patient who is at high risk for permanent joint disability by letting her psoriatic arthritis go unchecked. Some of you looking at this scenario might have said, you know what, I'm going to switch her to certolizumab. Well, certolizumab is considered the ideal biologic for patients with psoriasis in the setting of pregnancy because it doesn't cross the placental barrier. But my argument would be, hey, you know, she's currently clear, and many times women during pregnancy, their psoriasis actually improves in the setting of pregnancy. So a lot of times we think like a third, and a third. 30% of patients improve, 30% of patients' psoriasis stay about the same, and a smaller portion, and about 30% can get worse. We do, however, often see psoriasis worsen in the postpartum period. Some of you might have thought, well, maybe phototherapy. I know phototherapy is pretty safe. And phototherapy absolutely is the safest treatment option in the setting of pregnancy, but I wouldn't start that unless her skin disease started to flare. We don't use it as a preventative type of therapy. And then some of you might have said, you know what, she's doing great. I want to continue her on guselkumab and monitor. So like I said, you really have to look at the data, and we have limited safety data that's available. She's treatment naive. Her skin is clear and she has no psoriatic arthritis history or current psoriatic arthritis symptoms. So I'd be hesitant to do that. But if she had brittle disease, if she had been on a number of prior biologics and had failed them, and you really said, you know, guselkumab is the drug for her and I can't afford to lose control and risk not being able to recapture control, then you really want to have a risk-benefit discussion with the patient, their OB. Oftentimes we get maternal fetal medicine involved. Of course, if they have psoriatic arthritis, we're getting our rheumatology colleagues involved. But that's really something that you have to look at the literature, look at the safety data, or recognize the lack thereof, and really have an informed discussion not only with your patient, but with the other care providers involved. And there was actually a nationwide population study, and this was older. This was published in the JAD back in 2011, but they essentially looked at about 1,400 mothers who had psoriasis versus 11,000 mothers without psoriasis, and they wanted to evaluate the risk of the following: low birth weight, preterm birth, C-section, were the infants small for gestational age, did the mothers experience preeclampsia or eclampsia, right? And what did they find? So they actually found that in women with severe psoriasis, they have increased incidence of low birth weight infants. And when they looked back at this population-based study, they found that a little over 12% of these pregnant women actually did receive systemic treatment during pregnancy. And of that group, there was no increased risk of low birth weight, preterm birth, needing a C-section, having infants who were small for gestational age, or pregnant women who developed preeclampsia or eclampsia compared to the others. And that really suggested that the disease itself, having psoriasis itself, actually attributes directly to the risk of low birth weight, not the treatment. And we know that having these basically unblocked inflammatory cytokines, right? This onslaught of inflammatory cytokines circulating day in and day out do have a negative effect on maternal and placental health. And we really need future studies to take a look at safety of various biologic medications in the setting of pregnancy. And they also want to look at studies that look at placental cytokine levels in women who are pregnant with severe psoriasis to really better understand this relationship. And over the next year or so, you will likely be seeing recommendations coming from the National Psoriasis Foundation as we prepare a manuscript on the treatment of women with psoriasis from preconception through pregnancy and lactation. And that, involves a number of experts, from dermatologists to maternal fetal medicine experts, gastroenterologists, rheumatologists, immunologists, embryologists, in order to really better understand how does the treatment that we're giving or want to give in the setting of pregnancy to our vulnerable patients with psoriatic disease, what truly is the risk? So in general, with psoriasis and pregnancy, we often think, mild, or what we really should be calling limited disease. We think about emollients, low to mid potency topical steroids. We of course want to avoid topical retinoids. They are category X, and tar-based products. For patients who are failing topicals, we might want to think about phototherapy. Phototherapy is a great treatment, and it's definitely safe in the setting of pregnancy, but you do want to consider making sure that patient is properly being supplemented with folic acid. And now if they're unresponsive to phototherapy, then we're thinking about moving on to biologics over the other systemic agents, because we have the most data on it. TNF biologics, for example, like certolizumab, is the preferred agent in the setting of pregnancy, again, because it doesn't cross the placental barrier. So again, it involves a risk-benefit discussion and getting all of our partners involved in the discussion when we're working with pregnant moms. So this is another great piece of literature that you can refer to: psoriasis, which patient for which therapy. So thinking about special populations as well as patients with chronic infections. This is one that I often refer to time and time again. So hopefully you'll find that one helpful as well. All right, so we've all experienced this, right? We have a patient that was doing well and they get a severe flare in the setting of therapy. So they're on therapy and they're flaring. What do we do? So let's take Chris. Chris is a 45-year-old gentleman. He has a 3-year history of psoriasis. He has a body surface area of 5%. He was started on tapinarof, 1% cream, with excellent response, and his body surface area is down to 1%. He has no family history of psoriasis, and he has no history of psoriatic arthritis, and currently does not have any psoriatic arthritis symptoms. He has a history of hypercholesterolemia, obesity, hypertension. He is a smoker, and he drinks 1 to 2 beers every night. So sounds pretty standard for a lot of our psoriasis patients. He's previously tried topical steroids, and he's had difficulty with compliance. He really liked the tapinarof. It's a non-steroidal option, and it helped improve his psoriasis down to 1% body surface area. And he felt quite satisfied with that. So you're probably asking, all right, what's the catch here? This seems too easy. Well, Chris was on vacation. He went hiking in the woods. He developed a severe contact allergic dermatitis from poison oak. He was out of state. He went to a local urgent care. He was given a 3-week prednisone taper. 2 weeks after he stopped the prednisone taper, he developed acute generalized pustular psoriasis. He developed pustules pretty much from head to toe, covering about 60% of his body. So Chris comes into clinic and you stop clinic, right? This is a patient who needs your full attention. This is a true dermatologic emergency. So how would you handle this? So you have a patient who is presenting to you with generalized pustular psoriasis. There's a good chance that you've never seen it before. Many clinicians go their entire career with either never seeing generalized pustular psoriasis or maybe only seeing it once. So it is quite rare. So I'm not saying you're going to be walking into clinic on Monday and seeing this, but if you do, you at least know how to approach it, know how to recognize it, and know how to think about how you might want to handle it. So what would your next step be? What would be an appropriate next step? Okay, Would you give him an immediate dose of secukinumab? You're like, hey, I have secukinumab in the fridge. I know it works really fast. Let me get something on board with him. He needs something quick that works fast. Okay. Do you administer spezolizumab? Okay, you might be saying, what is spezolizumab? And we're going to talk about that. Would you add phototherapy? D, would you add cyclosporine? E, would you add acitretin? F, would you add methotrexate? Or A, would you add apremilast? Before you answer, let's first talk a little bit about generalized pustular psoriasis. So generalized pustular psoriasis is a rare variant of psoriasis. It's a clinical emergency. We know that IL-36, the IL-36 cytokine plays a central role in generalized pustular psoriasis. And essentially what it does is it plays a crucial role in recruitment of neutrophils. So when you biopsy these patients, you actually see a lot of neutrophils. So IL-36 is really integral in the recruitment and activation of neutrophils and Th17 in psoriatic skin. And you can see generalized pustular psoriasis arrive de novo, kind of out of nowhere in a patient with no prior history of psoriasis, or you can see it develop in a patient with a prior history of plaque psoriasis. And the number one trigger is systemic corticosteroid withdrawal. So this is why we don't like to give our patients with psoriasis systemic steroids like prednisone, okay? Other triggers, infection, hormonal changes, pregnancy, we can see that. And we know there are some genetic signals that we've learned the more we've learned about GPP. Patients often will have systemic symptoms, fever, feeling generally unwell, their skin is very painful. These patients really often do need to be admitted into the hospital, and this can potentially be fatal, okay? So let's think about our possible options now. Knowing what we know about generalized pustular psoriasis, how dangerous it is, and basically the pathophysiology behind it, what do we want, right? So we want to think about something, right, that first works fast, right? We know that this is a clinical emergency. So I'm looking at my kind of menu of options here, and I'm going to cross some things off the list that I know don't work fast. So methotrexate, that's a slow medication, 6 to 12 weeks to really get working. Why else might I not want to consider methotrexate in Chris? What do we know about his social history, right? He drinks some alcohol. He's obese, right? So what do we know about obesity and methotrexate? Right? Increased risk of fatty liver, right? So increased risk of hepatotoxicity, right? So our patients with psoriasis are already at a higher risk of fatty liver disease. You combine fatty liver disease with methotrexate, and you are putting a patient at very high risk for hepatotoxicity, okay? So we really want to avoid that. All right, so methotrexate is off our list. Acitretin. So some of you might have looked at acitretin and said, oh, I think I remember hearing acitretin is good for pustules. You're not wrong. Acitretin is good for oftentimes palmar plantar pustulosis, but it's not going to be something that we use in generalized pustular psoriasis. It's slow. It's not great at reducing inflammation when it's widespread. When we think about acitretin, I think more about, again, palmar plantar pustulosis. What about cyclosporine? You might be thinking, okay, I remember it works quick. It's a rescue medication, but I haven't used it before because up until this point, my biologics have gotten me to where I need to be in getting patients clear, almost clear really quickly. All right, so we'll keep that off. We're not going to take that off our list yet. Who would add phototherapy? Well, phototherapy, think about it this way, never put hot skin in a hot box. Okay, so you always want to cool somebody down before they go to phototherapy. So phototherapy, we know takes 8 to 12 weeks to get working. We don't have that kind of time in Chris. He's really suffering. So we're going to take phototherapy off of the option, off as an option. Would you administer spezolizumab? Okay, so you're thinking, what is spezolizumab? I think I remember going to a product theater about it. I think it has something to do with generalized pustular psoriasis. I think they need to be admitted or need it as an IV infusion. So yeah, I think we should keep that on our list. And then who wants to administer an immediate dose of secukinumab? Well, secukinumab is, obviously an IL-17 inhibitor. We know our IL-17 inhibitors work pretty quickly, but this individual is going to need more than that, okay? He needs something that works, near immediately. So that leaves us with our two options, spazolizumab or cyclosporine. So spazolizumab is an IL-36 receptor antagonist. There's a few different dosing regimens. It is the only FDA-approved medication for generalized pustular psoriasis. And you can see these different dosing regimens here, one for active flare, maintenance after an active flare, and maintenance without an active flare. For someone like Chris in this clinical scenario, he is having an active flare, so he would get 900 milligrams intravenously once, and if the flare persisted, he could get another dose of 900 IV 1 week later. So you want to do that, but let's say you're in the middle of the country and you're the only derm practitioner for 50 miles. Your nearest infusion center is 75 miles and your patient's not going to be able to get there. Or spazolizumab just is not available at your institution. So you have to start cyclosporine and you start sweating because you say, oh my gosh, I haven't used cyclosporine yet, or it's been a really long time since I've used cyclosporine. So this is when you dig out this great CME article that was published in the JAD. Again, this is going on 15 years, but it's an oldie but a goodie. It's the use of cyclosporine in dermatology, part 1 and 2. And it takes you from everything from pre-workup to dosing, to dose titration, to monitoring. So this is really definitely something you want to take a look at. So cyclosporine dosing. So generally, cyclosporine dosing, you should never exceed 5 milligrams per kilogram. Okay, usually the starting dose is anywhere between 2 and 3 mg per kg. So we wanted to start Chris on 2.5 mg per kg, somewhere in the middle there. He's 105 kilograms, which gives us a daily dose of 260 milligrams, and we should divide those in 2 doses, right? So about 130 milligrams per dose. And you hear me saying about, right? About because cyclosporine is only given in capsules with the denoting 25, 50, or 100, right? So we can't get super exact, but what you notice that I'm doing is I'm always kind of rounding down a little bit rather than rounding up. And cyclosporine comes in a few different formulations as well. And we usually prefer the modified, which is preferred. The brand is Neorel, but the modified cyclosporine has better absorption. And like I said, it's supplied in 25, 50, and 100 milligram capsules. So the starting dose for this patient, like I said, we calculated it out to need about 260 milligrams a day. So about 130 milligrams per dose. Well, I can get close to that with 125 milligrams BID, okay? So we wanna start cyclosporine, we have the dose that we wanna start, but before we start cyclosporine, what do we wanna check? A urinalysis, B, a complete metabolic panel, C, a complete blood cell count, D, a lipid panel, E, a magnesium, F, a uric acid, and G, a blood pressure. Well, when you see that many options, always think about all of them, right? So cyclosporine is one of those medications that is a rescue medication. It works incredibly quickly. It does have a lot of potential side effects and toxicities. So it is something that you need to monitor patients on extremely closely, okay? So patients need all of these tests done prior to starting cyclosporine, including your other labs that you would get prior to starting someone on a systemic immunosuppressant. So things like hepatitis B, C, HIV, your quantiferins or your PPD or your tuberculosis screening. So you want to make sure that you're doing all of the kind of pre-biologic lab screening plus these, including a blood pressure. Okay, so we start patient on 125 of cyclosporine twice a day, and his lesions begin clearing in 2 weeks. At his 4-week follow-up, his blood pressure was elevated, 162/98. Okay, so 162/98, his blood pressure is creeping up. We know he has a history of high blood pressure. So the recommendation is if you have a patient whose blood pressure increases, you do want to consider a dose reduction by anywhere from 25 to 50%. So we lowered his dose to 75 twice a day until he completely cleared. So by week 16, he was completely clear. Now, again, this entire time, every 2 weeks, we are checking all of these things, the urinalysis, the CBC, the CMP, the lipids, the MAG, the uric acid, the blood pressure, right? So every 2 weeks. So this is very work intensive on the part of the clinician, on the part of the patient. So you need to make sure you're starting it in a patient who's going to be compliant with this, because we really don't want them to get into trouble. Once he was cleared, we decided to start tapering his dose by about 25% every 2 to 3 weeks, and he remains clear to this day. So again, cyclosporine is a drug, again, that's used for rescue. It's not used for chronic maintenance. So we use to rescue patients who are flaring from an acute crisis. We may use it to bridge them to systemic therapy, but it's never the end all be all in terms of keeping them on chronic therapy. We really worry about nephrotoxicity. We worry about their blood pressure. We worry about their lipids and their renal function. Okay, so again, can be used very, very safely. And I strongly recommend that you take a look at that publication that really takes you through the steps so that you familiarize yourself with that. And don't be afraid to use it if you need it. All right, so our next scenario. So everyone at one point or another in their lifetime is going to be faced with the need for surgery, whether it's elective, whether it's planned, or whether it's emergent. So it's important for us to kind of know how to handle this. So here we have a 42-year-old woman with a 6-year history of severe psoriasis and psoriatic arthritis. Her BMI at baseline was 32. And her weight was 250 pounds. She's been on ixekizumab for 3 years, and she's 100% clear, and her PSA is in remission. Through diet and exercising, she lost 80 pounds, and her BMI is down. She wishes to undergo abdominoplasty to improve her appearance. When would be an optimal time to schedule her surgery, since she is on a biologic agent? So this particular patient is looking at an abdominoplasty. Another patient may be looking at a knee replacement. Another patient may have cancer in their lungs, and we'll talk a little bit about that, and need to go through surgery. So we're thinking about all of these different potential surgical scenarios. And what I want you to think about is, well, how risky is that particular surgery? So if you look at the table over on to the left, they kind of group these into high risk, intermediate risk, and low risk procedures. So our patient with the abdominoplasty, this would be an uncomplicated abdominal operation, okay? We're not penetrating into the GI tract, right? We're not opening up the stomach or the intestines, for example. This is going to be generally, it's a larger surgery, but it's an abdominoplasty versus something like cardiac surgery, right? We know our patients who have a history of psoriasis are at much higher risk for cardiovascular disease. So let's say a patient gets scheduled for a CABG, right, a coronary artery bypass graft. That is a high-risk procedure. And in those scenarios, we often think about, for high-risk scenarios, we think about holding a medication. For low-risk scenarios, we think about proceeding with biologic therapy. But how do we hold it? And for how long do we hold it? So I want to direct your attention to some recommendations from the National Psoriasis Foundation. So biologics and oral agents can be continued through low-risk surgery. So let's go back here and take a look at our low-risk surgeries like cystoscopy, endoscopy, derm procedures, breast biopsies, eye procedures, right? Those are all considered low-risk procedures, and we don't need to hold the biologic or systemic agents prior to these surgeries. But for intermediate and high-risk surgeries, we really have to think about case-by-case basis, right? The most conservative approach always is to discontinue the biologic for 3 to 4 half-lives, but this might not be feasible or necessary in all cases. So let's take a look at the half-life, right? Let's look at the half-life, say, of ustekinumab. The half-life of ustekinumab is 21 days. The conservative discontinuation time recommended would be 12 weeks, and then 2 to 4 weeks. Some say 2 to 4 weeks, some say 1 to 2 weeks after surgery, you can resume. That's a really long time for a patient to be off of medication. So again, we have to really engage in the shared decision-making with our patient, with the surgeon, and really discussing, okay, what are our potential options if we hold this medication? What are our potential options in terms of resuming the medication? When can we do this? So most conservative approach, as we said, is to discontinue for 3 to 4 half-lives. However, when I mentioned that patient earlier in the first case, she doesn't have brittle disease, she doesn't have psoriatic arthritis. This patient has severe disease and she has psoriatic arthritis, right? We don't know how many different biologics she's been on, but that's a really important question to ask, right? Knowing your patient's treatment history is incredibly important because it's going to give us a sense of how many biologics have they been exposed to, or do they have really difficult to treat psoriasis, and I really need to hold on to this biologic that's working well for them and avoid any disruptions in therapy. So these are all of the things we have to think about. So it really is an informed risk-benefit discussion. And the biologic, in most cases, can be resumed 1 to 2 weeks after surgery, assuming there haven't been complications, right? So post-operative infections are possible, then we should really wait to resume the biologic until after that post-operative complication, like an infection, has been cleared. The other aspect to this case that I wanted to highlight was psoriasis and obesity, okay? We all know at this point that obesity and psoriasis often go hand in hand. And I think many, many, many years ago, it was not well understood, the connection. It was often chalked up to, well, patient with psoriasis has a poor self-image. They may be depressed because of their psoriasis and not want to be seen at the gym, not exercise, so therefore they're at greater risk for developing obesity. But we actually know that the risk of developing psoriasis and the risk of developing obesity is a bidirectional relationship. And this was data from an epidemiologic study that looked at the risk of developing psoriasis, so the relative risk of psoriasis development as it pertains to the patient's BMI. And you can see these different BMI stratifications here. And then you can see the relative risk of psoriasis development on the right. And the risk of psoriasis was really found to increase in a dose-dependent manner. And there was an additional 5% of increased risk of psoriasis with every 1 unit increase in BMI. So as patients got heavier, right, or the heavier the patient, the greater risk of psoriasis. So that's we're going to talk a little bit in a few moments as to why that is. And we also know that metabolic syndrome components increase as body surface area increase. So components of metabolic syndrome include elevated triglycerides, glucose, and obesity. And we can see here body surface areas varying from body surface area less than 3, 3 to 10, and over 10, okay? These 3 different groups based on disease, psoriatic disease severity. And we see here that as body surface area of psoriasis increase, so did the rates of obesity, dyslipidemia, and impaired glucose control, okay? So the more severe the psoriasis, the greater likelihood of obesity, impaired glucose or impaired glucose control, and dyslipidemia. Okay, so that's really very important. So we know about this, right? We know, right? But do our patients know? Do our patients really understand? And this was, a quality improvement pilot study that was published in the JAD International in 2024, and it was characterization of metabolic risk awareness among patients with psoriasis. And it was a relatively small sample size, right? 101 patients completed this survey. 78% of those patients saw their primary care provider within the past year. 34% reported that psoriasis and cardiovascular disease connection was discussed. So only 34% reported that the psoriasis cardiovascular discussion happened, or that connection was made to them at that visit. And then 83% of them actually desire education and actually want it from their dermatologist. So this is in our wheelhouse, and we should be educating our patients with psoriasis about the cardiovascular risk factors. And sometimes I think we think we're doing this, right? And we're saying, you should really see your primary to check your lipids and check your hemoglobin A1C and check your blood pressure and make sure all of those things are where they need to be. But it is really important to say it to patients in a way that they hear you, right? And you can say, listen, I don't know if you know this, but having psoriasis actually increases your risk of cardiovascular disease. There is a connection between your psoriasis and your cardiovascular health, right? So being really blunt, really straightforward with patients so that they hear that connection, because again, only 34% of them reported that connection was being made for them. I think probably it was underestimating things. I think we are doing that, but patients maybe aren't hearing it. So being very, very straightforward and really in plain language, explaining to patients that there is a connection between their psoriasis and their cardiovascular disease. So a bit more on obesity. As I mentioned, there is a bidirectional relationship between obesity and psoriasis development. So we know as patients become more obese, they're more likely to develop psoriasis. With greater psoriasis severity, there's greater obesity. And we know that through a lot of research that obesity is a pro-inflammatory state. So it's not just about the patient not being able to exercise because they're embarrassed for their skin. Adipocytes drive inflammation, so fat cells drive inflammation. And obesity is an independent risk factor for development of psoriasis. Patients with obesity, in their adipose tissue, they have increased levels of pro-inflammatory cytokines like IL-8, IL-16, IL-1, and TNF-alpha. Pro-inflammatory environment really can impact insulin signaling, lipid metabolism, and fat development, okay? And we know that higher weight was associated with a reduced odds of improving their skin with treatment, okay? So higher weight meant patients were less likely to achieve a PASI 90 at 6 months post-therapy in this particular study. So we know that our patients who have a higher BMI are not as likely to clear with traditional therapies as are patients who are in a healthy BMI. So those are all really important things to consider when we're caring for our patients with psoriasis, because obesity is an epidemic, okay? We know that adipocytes, inflammation, and obesity run together, right? So, and really the key, the way I like to think about, how does being obese drive inflammation? And it's all in the adipose tissue. So adipose tissue, essentially you can see here, it's a little bit of a busy slide, but adipose tissue results in increased macrophages, recruitment of macrophages into the adipose tissue is an early event in induced adipose inflammation, okay? So obesity-induced adipose inflammation is driven by the macrophages. And adipose tissue, within those macrophages actually express CCR2, and they recruit additional monocytes and macrophages. And the activated macrophages then produce inflammatory cytokines like IL-6 and TNF. So there will be, we already know there's a lot of talk about obesity and obesity management, right? And the different medications that are now out there helping our patients who are obese get to a healthier weight. We know that a lot of these anti-obesity medications also have anti-inflammatory properties, again, because they're driving down in part the amount of adipose tissue, right? And we know adipose tissue drives inflammation. So it will be very exciting to see how our patients with psoriasis who are obese, who may be on some of these anti-obesity medications, what happens to their psoriasis, not only as a factor of reducing the overall amount of fat tissue, but also the innate qualities of these anti-obesity medications to reduce certain to reduce certain inflammatory cytokines. All right, we're going to talk a little bit about malignancy during therapy. So unfortunately, we are caring for patients and taking them through the highs and lows of life. And sometimes that involves the development of a malignancy while they're getting therapy on a biologic. So let's talk about a situation. 52-year-old gentleman with a 25-year history of psoriasis and psoriatic arthritis, with a max BSA history of 30%. He had failed methotrexate and failed phototherapy, and he was started on adalimumab, and his body surface area is now down to 1%, and he's super happy. Unfortunately, he got his routine colonoscopy and was found to have colon cancer. His adalimumab was stopped, and the patient underwent chemotherapy and surgery. 6 months after completing chemotherapy and healing from surgery, his BSA is back up to 20%, and he's pretty miserable. He has a history of hypertension, type 2 diabetes, a BMI of 28. He's a non-smoker, and he drinks 1 glass of wine every night. So fast forward another 6 months, his colon cancer is in remission, but his psoriasis, again, 20%, and he's not happy. The patient requests that we resume his adalimumab. He says, hey, listen, I was doing great on the adalimumab. Can we just get started? It's been a year. What would be your next step? Would you resume the adalimumab? Would you initiate another biologic? Would you start phototherapy? Would you start apremilast? Would you start cyclosporine? Or would you start acitretin? And you were thinking, I could do acitretin with or without phototherapy. All right, so let's think about some of these options here. So we're going to hold on resuming the adalimumab, right? We might be a little bit hesitant to say, you know what, TNFs do have a box warning for malignancy. I'm a little bit hesitant to put him on the adalimumab. Initiate another biologic. Well, I'm not sure if I'm going to run into the same issue with these other biologics. Let me think about that a little bit more. I'm going to start phototherapy. Could you start phototherapy? Absolutely. Phototherapy is a reasonable option. We know it's 100% safe for patients. It does not increase their risk of solid organ malignancy or recurrence of malignancy. What's the downside to phototherapy? Right, it can be a little bit cumbersome for the patient. It can take them a while to get to and from appointments. It can be very costly from both a time and a finances standpoint. So we may not be able to get it started in him if it doesn't work for him logistically. Apremilast also potentially a nice option for this patient. Non-immunosuppressing, so the mechanism of action, it's a PDE4 inhibitor. This is something that we could definitely consider. Cyclosporine. Cyclosporine, again, rescue medication, not really a scenario where I'm going to consider starting this, because this has been kind of a slow burn with him. It's been 6 to 12 months now that he's sitting at a body surface area of 20, which I would say is quite a long time. I'd probably want to move on that a little bit sooner. But we're not really in kind of rescue mode right now. And then acitretin, with or without phototherapy. That's reasonable, okay? So acitretin is a mediocre medication when it comes to efficacy, right? About 40-something% of patients will achieve a PASI 75. So not great, but not terrible. Could we add it with phototherapy? Absolutely, and boost the efficacy of acitretin. That's called re-UVB, right? So retinoids plus UVB. Sure, we can consider that. We want to consider some of the side effects that we can see with acitretin, like dryness, potential pseudotumor cerebri. We want to think about, onset of action, right? It doesn't work super fast. Okay, that we might have a little bit of time, but not a bad option. So we have a few options here, right? So the thing with these clinical scenarios is that there isn't always one right answer, right? But you just want to think about, how am I thinking through these menu of options? So what do we do in this scenario? So we spoke with the patient's oncologist, all right? So we have to engage subspecialist help. Okay, so you really want to be working amongst the interdisciplinary team. So we discussed with the patient's oncologist. The oncologist stated that they really prefer to avoid TNF inhibitor therapy after malignancy. Many times, oncology would prefer to avoid TNF therapy if it's been within 5 years of a solid organ malignancy. So that's really no surprise to us. But they said they would be okay if we wanted to use an IL-17, an IL-23, or an IL-12-23, like ustekinumab. So you decide to initiate therapy with ixekizumab, an IL-17 agent. His psoriasis cleared and he's doing really well, and his psoriatic arthritis is under control. We continue to monitor the patient closely with both his oncologist and his dermatologist. But the good news is that we tend to feel that IL-17 and IL-23 as IL-12/23 agents are safe in the setting of malignancy, but of course need the okay of the patient's oncologist. So there are several studies that do support the favorability of the safety profile of biologics in the IL-17, IL-23, IL-12/23 category when it comes to malignancy. There were a few studies in patients with a prior history of cancer that showed no increased risk of recurrence in those treated with biologics compared to non-biologic therapy. The reason we call out TNF inhibitors and we avoid using those in patients with malignancy is that TNF regulates tumor growth factor, okay? And recent studies do not show an increased risk of new or recurrent malignancy in patients with psoriasis treated with biologic agents, with the exception of non-melanoma skin cancer, which is why it's incredibly important that our patients with psoriasis are getting their routine skin checks as well. Age-appropriate malignancy screening is what we recommend for all of our patients on biologics. And again, care coordination, interdisciplinary discussion, and making sure we're, consulting the guidelines of care are incredibly important when we're dealing with patients who are undergoing treatment for malignancy or are post malignancy treatment. I really thought this article was great, the biologic treatment algorithms for moderate to severe psoriasis in various comorbid conditions, and they do call out malignancy as a special population as well, and I think it's definitely worth a read. Here's another clinical scenario that we absolutely face on a regular basis, and I'm sure you have as well. The good news is that our patients with various solid organ malignancies like lung cancer or bladder cancer or melanoma, right, are living longer lives because of immunotherapy, right? Immune checkpoint inhibitors have really changed the landscape of oncology treatment and what it means to be living with cancer. So this 66-year-old gentleman has a history of metastatic melanoma, and he is on pembrolizumab. And he presented to us with new onset silvery scaling plaques on the torso, the arms, the legs, with a body surface area of about 15%. His brother has a history of psoriasis. He's been using hydrocortisone 1% cream without any relief. So a moment to talk about anti-PD-1 or PD-L1 induced psoriasis. So these anti-PD-1 medications or PD-1 inhibitors like pembrolizumab, nivolumab, durvalumab, they are approved for a growing number of late-stage malignancies that have very high skin toxicity rates, okay? Anywhere from 14 to nearly 17%. We do see a lot of these where I practice. They can look like a lot of different things. You can see PD-1 inhibitor induced alopecia areata, PD-1 inhibitor induced vitiligo, bullous pemphigoid, lichenoid dermatoses, and psoriasis. So I've seen a number of patients with a psoriasiform dermatitis related to PD-1 inhibitor therapy. It can kind of, again, these immune checkpoint inhibitors are enhancing or revving up the patient's own immune system to fight the cancer that's present, but it can also have an impact on other organs in the body, especially the skin. So I've seen it de novo in patients with no history of psoriasis. I've also seen it in individuals with a history of psoriasis, and their psoriasis then gets worse. And we tend to see it happen more frequently, at least the or psoriasiform dermatitis happen more commonly in individuals who have a personal or a family history of psoriasis. So in these scenarios, right, our goal is to allow the patient to be able to stay on their PD-1 inhibitor to fight their cancer, and we can support the skin, get them through it. Okay, 9 times out of 10, we're able to manage these patients. We manage them through this hiccup in their therapy. And a number of things can be done for patients with anti-PD-1 induced psoriasis. This is a great review article of the cutaneous manifestations of checkpoint inhibitors in melanoma patients. So this is definitely worth a read, but it's very well documented. And as I mentioned, keeping these patients on their anti-PD-1 therapy is the goal. I communicate with the oncology team. Many times the oncology team might adjust the dosing regimen, maybe space out infusions a little bit more depending on the therapy. We'll always employ topical steroids. This is one scenario where sometimes we will use systemic steroids, but I say that with an asterisk because you do want to be careful with that, because you also do not want to have patients on such a dose that it's inhibiting the ability of the PD-1 inhibitor to actually do its job. So we use a lot of phototherapy in these patients, acitretin, apremilast, sometimes methotrexate is used, and sometimes we can use biologics as well. Again, typically not of the TNF inhibitor class, but you can use biologics. Generally speaking, the most common therapies are going to be topical steroids and phototherapy. All right, we have all experienced this as well, loss of efficacy of a medication. Patients are losing response, okay? And they come to you and say, listen, it's just not working anymore. So in this patient, Lindsay, she's a 40-year-old woman. She's been on ustekinumab for 12 weeks for the past 2 years. Excellent response. Her body surface area previously was 0.5%. But at today's visit, she notes that she's having more activity on her scalp and her lower extremities. It's incredibly bothersome to her, and she now has a BSA of 8%. So she's really climbed back up there. So what might be some questions that you ask her? A, have you had any missed doses? B, have you had any recent illnesses? C, do you have any joint pain, swelling, or stiffness? And D, what topicals are you using? Well, why do we want to ask these questions? We want to ask all of them, right? We know that disruptions in therapy can impact efficacy. We also want to know, well, if you haven't missed any doses, tell me what your disease is doing as you near your dose. So as I mentioned in the presentation of the case, she's on ustekinumab every 12 weeks. Sometimes you can get you can get insurance to approve Q8-week dosing. So that's, off-label, but is done quite commonly. So if she notes flaring of her skin disease at like week 10, or as her dose is nearing due, that might be something to consider. Any recent illnesses? We know that something like an upper respiratory tract infection or strep throat or COVID can temporarily cause a flare in the disease. So you want to kind of get a sense of, was there something that kind of triggered this flare? Is this just a blip in her radar, or is she truly losing efficacy? I would venture to say she truly is losing efficacy based on the amount of body surface area that she has, but it's an important question to ask. Do you have joint pain, swelling, or stiffness? That's something that we should ask at every visit, right? Not just in these complex scenarios, right? We want to screen for psoriatic arthritis. Ustekinumab is really not the best choice for psoriatic arthritis, so it may be that, hey, she was doing fine and now she's getting joint pain and stiffness that's breaking through the ustekinumab, and that would really greatly impact my next therapeutic choice. Okay, I want to make sure that I'm using a biologic that not only works for her skin, but is going to work well for her psoriatic arthritis. And then what topicals are you using? Topicals can and really should be used adjunctively for patients with limited disease. They can be used on, as monotherapy, but for someone like this, they really shouldn't be used as monotherapy. I do try and maximize a topical regimen for a patient, even when they're on biologics, so that they have something that they can use if they get into a little bit of trouble. So she denies any missed doses, recent illnesses. She denies joint pain, swelling, stiffness, or dactylitis, so no sausage digits. She's using clobetasol foam in the scalp every day and doesn't really like using topicals on the legs because it's messy and it ruins her clothes. And her scalp psoriasis is absolutely driving her crazy. She has a past medical history of diabetes, obesity, and hyperlipidemia. Her family history is significant for multiple sclerosis in her sister. And she notes she's had a really busy year. She's been having a lot of GI issues and is currently being worked up for new onset diarrhea and abdominal cramping. So Lindsay has a lot going on. And you talk to her about her next steps in management, and you recommend what? Adding apremilast, starting adalimumab, starting ixekizumab, or starting risankizumab. So let's just take a look at all of this information that we have here. So things that are good, right? She doesn't have any joint pain, swelling, stiffness, or dactylitis. That's good, okay? She has diabetes, obesity, hyperlipidemia, okay? Her scalp is really what's bothering her. She has a family history for multiple sclerosis, and she's got new diarrhea and abdominal cramping. Okay, so based on some of these key things that we pointed out here, what do we want to consider in terms of what will we do for her? Okay, she's on ustekinumab. Do we want to add apremilast? Do we want to stop the ustekinumab and start adalimumab? Do we want to stop the ustekinumab and start ixekizumab? Or do we want to stop the ustekinumab and start risankizumab? So let's think about adding apremilast. Okay, so adding apremilast, you might be thinking, okay, it can be used in combination, but I might not want to choose it with the diarrhea and abdominal cramping. Not that it's a contraindication, but we know that apremilast can contribute to some GI side effects. So I might want to say that might not be the best option for her. It's not wrong, but it might not be the best option for her. Starting adalimumab, you might be thinking, well, I know that patients with psoriasis do have an increased risk of inflammatory bowel disease. That is definitely a comorbidity that we can see. And I know that adalimumab is approved for inflammatory bowel disease. So maybe I'll get her started on the adalimumab to kind of hedge my bets here. Well, I'm not going to do that because of why? Her MS, right? MS, her family history. It's a contraindication in someone with MS. It's a relative contraindication in someone with a family history of MS. So I have so many other options out there. Why choose that, right? We're going to avoid that. So again, comorbidities, knowing that TNF inhibitors can unmask demyelinating diseases in individuals who are genetically predisposed. So I am going to avoid this TNF inhibitor in this patient. Starting ixekizumab. Well, ixekizumab is an IL-17 agent. What do we know about IL-17 agents? Shouldn't be used in individuals with inflammatory bowel disease. Now, again, we don't know what her GI issue is yet. She's being worked up, but we know that she's at greater risk for developing inflammatory bowel disease. So again, similar, why would we go there, right? So let's hold off on that. So we can consider starting risankizumab. Okay, I think that seems like a good option, but kind of let's go through each of these. So for those of you who thought about adding apremilast, it's an off-label combination therapy. Apremilast has been proven to be safe and effective in some patients. Data is limited, but it has been used in combination or add-on therapy. Starting adalimumab, we talked about family history of MS. We really should avoid it. Ixekizumab, IL-17 agents, should be avoided in patients with inflammatory bowel disease. And for her, I'm thinking IBD until proven otherwise. And then starting risankizumab. We could have also maybe started guselkumab, right? An IL-23 agent. Risankizumab is just one of the IL-23 agents that's also now approved for Crohn's and is effective in patients with inadequate response to ustekinumab. Okay, so this is definitely a study that was done, switching patients who were on either ustekinumab or adalimumab and plaque psoriasis, and those patients who were switched to risankizumab, both of them did better, whether they were previously on adalimumab or ustekinumab. So we know that risankizumab can outperform. And then, as I mentioned earlier, combination therapy with apremilast, with different biologics. This is a great review article. This is something that you could consider. So again, there's never just one right answer. There are definitely things that are you want to avoid, right? Things that are not great choices, but there often are multiple ways to get a patient clear or almost clear. But what I can't stress enough as we come to close of this session is with any scenario, but especially your complex scenarios, history is the most important thing. So medication history, right? So what other medications are they on? But what other medications have they tried for their psoriasis? And how did they respond? Were they complete failures? Were they partial failures? Did they lose response after 5 years on the medication, right? So kind of really understanding the history of their therapeutic regimens, their past medical history, right? Their social history. All of these things impact how we make the best choice for our patients when we're thinking about therapeutic options. Comorbidities, right? We have to know our comorbidities. We have to know the comorbidities to expect from our patients with psoriasis. We have to know the comorbidities to think are potentials for our patients. And we have to know which comorbidities play well with certain medications and which do not. And you always consider your options because there may be more than one. So just like we did in today's session, get out your red pen, get out your list of medications and think through one by one. What's good about this? What's bad about this? Is this a good option or why is this a bad option? Collaborate. Ask your colleagues, ask your collaborative physician, ask people around you how they might manage a particular scenario. Collaborate with other disciplines, right? So we do not exist in a silo, nor do our patients. Our patients are complex, so we have to make sure we're reaching out to the different disciplines, whether it be rheumatology, whether it be OB or maternal fetal medicine, whether it be gastroenterology or oncology. We all have to talk together so that we can make the best, safest choice for our patient. And then never forget to consult the literature. You are not alone. You may be the only provider in your office, but there is an abundance of literature out there, and I gave you some snapshots of some great resources to look for. You can always look to the National Psoriasis Foundation for recommendations and treatment guidelines and recommendation statements. That's a great place to start. But hopefully you found going through some of these complex scenarios helpful. Maybe some of them were some scenarios that you experienced in clinic, and maybe there'll be some that you'll come across in the near future, and you'll have a great way to think about how to take care of these patients and really methodically think about how to take the best care of them. I hope you enjoyed this, and I hope you got something from it. Thank you, and have a great day.
Thank you, Veronica. That was excellent. We really appreciate your time. And for those of you who are interested in claiming credit, please complete the post-test and evaluation, and you will be sent a CME certificate. Thank you.